Hi everyone, might get started. Thank you all for joining us for this webinar, which is part of our series of presentations that are focused on applying evidence into practice, which is part of the comorbidity project funded by the Australian Government Department of Health and Aged Care. My name is Christina Morell. I'm an Associate Professor and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney, along with Alexandra Azzi, Alex, who is a project officer on this project. We are back again and very pleased to be facilitating today's webinar, which is being presented by Dr. Vicki Giannopoulos. Before we start, I'd like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting and recognise that we are meeting across Australia today. The traditional owners of the lands that I'm currently on are the Gadigal peoples of the Eora Nation, but I would also like to acknowledge the traditional owners of the lands across Australia for everybody else who is here and pay my respects to elders past, present and emerging. I extend that respect to any Aboriginal and Torres Strait Islander people who are here today. I'd also like to recognise and acknowledge the many people with lived and living experience in mental illness and substance use, as well as their families, carers and loved ones, many of whom have generously contributed to the development of the guidelines on co-occurring conditions, as well as our other resources. Just briefly, whether you're joining us live or watching the recording, you're all in listen-only mode, which means that we can't see or hear you. So I'd like to draw your attention to the Q&A and chat buttons on your screen. If you have any questions for Vicki during the presentation today, please feel free to use the Q&A button. If you have any comments or anything other than questions for Vicki, please use the chat button. This just helps Alex and me keep track of what questions we pass on to Vicki, and if there are any other requests for support or technical issues that we need to respond to, we can identify those. The slides for this webinar are already available to download on our website. The link is on screen there, and this recording will be available in the next few days. So to get started, today's webinar is on depression and alcohol and other drug use and what clinicians need to know. And I will hand over to Vicki in a moment, but just before I do, I want to mention that you can access our webinar library and also register for our next webinar at our website. And thank you again to everyone who's been coming along to this series, either watching live or watching the recordings later and sending us through feedback and just suggestions for webinars. And in fact, today's topic and also our next one in September has been organised in response to some of your feedback. So thank you again for coming along and engaging with us. Please continue to give us suggestions for what you'd like to see as part of this series, and we'll see what we can do. And now it's my great pleasure to introduce our presenter for today, Dr. Vicki Giannopoulos. Vicki is a senior clinical psychologist at Sydney Local Health District Drug Health Service, working in treating addictions. Her research is in the area of translational research on evidence-based practice, suicide, clinical supervision, and comorbidity management. I'm so very pleased that Vicki is able to be here and present as part of this series, and I will hand over to her to get started. Thank you, Vicki.
Hi everyone, I'm Vicki Giannopoulos. I'm a senior clinical psychologist from the Sydney Local Health District, and today I'll be talking to you about what clinicians need to know about working with patients who have depression and a comorbid drug and alcohol problem. Before we get started, I'd like to start by doing an acknowledgement of country and acknowledging that we are living and working on Aboriginal land. And we'd like to acknowledge all of the traditional owners of the land and pay our respects to elders, past and present. These are some of the key learning outcomes we hope that you've achieved by the end of today's webinar. And the first is looking at ways to identify comorbid depression in patients who already have a substance use disorder. We'll talk about the current evidence-based practice for treating this comorbid population, but we'll mainly focus on looking at some practical treatment strategies for treating patients with comorbid depression and substance use disorders. We'll also talk about key challenges with working with this group and some little practical strategies to help with these challenges. Now, it's really important to remember that the prevalence of depression is so high in patients with drug and alcohol use disorders. Although studies have found that it's about 1 in 3 individuals with alcohol use disorder will have a comorbid depressive disorder, we all know that in clinical practice, these numbers may be actually higher than 1 in 3. And it's important to look at this population because, you know, that actually having depression increases your risk of relapse after any period of drug or alcohol abstinence. And we know that there's a very strong link between depression and substance use, both for alcohol and drugs as well. And patients who've got depressive symptoms are more likely to have a more severe pattern profile and have a greater severity of depression when they also have a coexisting drug and alcohol problem. So why is this comorbidity important clinically? Well, not just because it's so prevalent, because having the two conditions leads to a worse outcome for both the substance use and the depression. And we know that this population doesn't usually respond well to standard treatment, and they have very high rates of treatment dropout. There are a number of models which explain why patients have this comorbidity in the first place. I won't go into them too much, but the two main models are the self-medication model, which basically states that patients have depression and they use alcohol and drugs to self-medicate and manage their depressive symptoms. The other model explaining this comorbidity is the neurotransmitter model, which states that chronic alcohol or drug use over time leads to depression due to changes in one's neurotransmitters. So we'll start by looking at how do you best identify depression in clients who've already got a substance use problem. Now, there are different ways you can do this. So the quickest and easiest way is to use a screener. Now, accuracy is reduced when you're using a screener, but if you're pressed for time or you've got some suspicions about someone, the best thing is to start off with a quick and easy screener. There are lots of them out there, but the best screener for depression they've found is to ask patients these two questions, and if you get a yes to answer to either of them, then you need to do further assessment. So asking patients, in the past month, have you lost interest or pleasure in things you usually like to do? And have you felt sad, low, down, depressed, or hopeless? So if they say yes to either, then it's recommended that you use a formal assessment tool or refer them on for assessment of depression. Now, there are quite a few assessment tools that are standardised out there for depression. For instance, the DAS-21, the BDI, the Hamilton Rating Scale for Depression, the Patient Health Questionnaire, the K-10, and the Hospital Anxiety and Depression Scale. But you can use any standardised scale that you prefer. So start with a screener, then use an assessment tool. Structured clinical interviews are also available, but they're usually reserved for clinical research studies, and they're quite lengthy and they can take a while to administer, but they can also be used to determine whether someone has depression or not. The two most common structured clinical interviews for depression are the SCID or the CITI, but usually an assessment tool is enough to diagnose depression. Keep in mind when you're identifying depression whether the depressive symptoms actually overlap with the alcohol drug use or alcohol drug withdrawal symptoms. So keep that in the back of your mind, because sometimes someone may appear quite depressed, but it may actually just be a symptom of their intoxication or their withdrawal. Now, there are two main types of depressive disorders in the DSM-5. The symptoms are exactly the same, but there are a few differences. So one of the depressive disorders is purely called depression, and the other in the DSM-5 is called substance-induced depressive disorder. The main symptoms are the same, such as sadness, emptiness, irritable mood, as well as some somatic and cognitive changes that, most importantly, they have to significantly affect the person's capacity to function in order to be classified as a disorder per se. Now, in the DSM-5, the substance-induced depressive disorder is related to someone's alcohol and drug use, and it can be due to active drug use or alcohol use, intoxication, or withdrawals. For instance, a number of substances have depression as a common symptom of their withdrawal. Cocaine does, methamphetamines do, and alcohol does as well. So according to the DSM, you can have a pure depression or a substance-induced depression. Sometimes it's very hard to work out which one your client has. How do you work out which one it is? Well, the DSM recommends that if someone has had a 1-month abstinence or significant reduction in alcohol or drug use, that should be enough time to exclude substance-induced depressive disorder. So if the client's been off alcohol or drugs for more than a month and they're still displaying depressive symptoms, it's more likely to be a pure depression. On the other hand, the patient's had more than a month abstinence and they no longer show signs of depression, it was likely to have been a substance-induced depressive disorder. At the end of the day, it doesn't matter a great deal which type of depressive disorder it is if you're faced with a client who's presenting as severely depressed, because as a clinician you would still treat the depression as promptly as possible, regardless of which of these two disorders the client has. So what's the current evidence-based practice for treating comorbid depression in patients who have a substance use disorder? Now, the two disorders are so highly prevalent, but unfortunately, there are few studies out there in the literature even examining the evidence-based practice for this population. What we do know, though, is the best practice for this group is CBT and motivational interviewing, and to use an integrated as opposed to a siloed approach. So what that means is if you are seeing your patient from a drug and alcohol setting, it's really important that you also address the depression rather than sending them somewhere else. So the best approach is to integrate the two disorders in your treatment plan. I won't go into the evidence too much, but I'll just talk about a few studies, like for instance the Cochrane Review in 2019, which was unfortunately only based on about 600 subjects and 7 studies. The studies were not of very good quality. There were very few controls, few pharmacotherapy combined trials, and often the treatments were lengthy, like in excess of 20 sessions. So the results of that are not very solid. The bottom line is we need more research into this population to make definitive decisions about what the best approach is. But we do know that clients who have integrated depression and alcohol and other drug treatment will have, with the greatest change in their depressive symptoms, also had a greatest change in their alcohol and drug use across times. So what that means is if you see improvements in depression in this comorbid population, you're also likely to see improvements in alcohol and drug use and vice versa. So the two are very related. Once the mood improves in treatment, you'll tend to see the alcohol and drug use improving as well, and vice versa. So in a nutshell, integrated cognitive behaviour therapy and motivational interviewing is the current evidence-based practice, but very few studies have been conducted in this field, which is absolutely surprising given that these two disorders are so highly prevalent. So how do we start integrated treatment with this comorbid population? What are the main key treatment components that you should include with someone that you're seeing with comorbid depression and alcohol and other drug use? Well, the first is obviously motivational interviewing, which is something that you would do not just at assessment, but at every session, because as we know, motivation to change is very changeable. Patients will change from minute to minute, from session to session in their readiness to change, and that's completely normal. The thing to keep in mind is you need to assess a client's readiness to change for their depression separately to their alcohol and drug use. They may be coming to you to change their drinking, for instance, but they may not be ready to address the depression that you've identified. They may feel that now is not a good time to start treatment for their depression, or maybe they don't acknowledge their depression as a problem, for instance. So you need to assess readiness to change separately for the alcohol and drug use than you would for the depression. Another key component is goal setting. So setting smart goals which are realistic and achievable, that are set by the client. They're client-led, not our goals. So looking at some concrete goals that they want to make in terms of changing their substance use and whether they want to change their depression as well. Psychoeducation is a very big component of integrated treatment with this comorbid population. And you don't just do this at assessment, but it's recommended that you keep identifying the link between their alcohol and drug use and their mood. Ideally, you want the client to be able to identify this link, but sometimes you may need to point it out to them that the two are often closely related. And I'll mainly talk about individual treatment today, but some of these strategies which I'll talk about have also been applied in group therapy and e-health online interventions as well. And there are also other treatments for this comorbid population, such as pharmacotherapy. Now, I won't be talking about pharmacotherapy today, but it's important to keep in mind that it can be a useful adjunct to your usual treatment as well. So the key component of integrated treatment is motivational interviewing, or assessing their motivation to change. So you need to keep in mind, as I said before, that their motivation to change will differ for changing depression to changing their substance use. You need to assess motivation for each one separately and frequently, because motivation fluctuates. There are various ways you can assess someone's readiness to change, but it's really important, first of all, to be familiar of the stages of change. Patients may not always be ready to change when they're seeing you. They will often alternate between contemplative and pre-contemplative, and you need to match your treatment style to their stage of change. For instance, if you are seeing someone who is being mandated to attend treatment with you, they may not be that ready to change. They may be ambivalent. There's no point diving into treatment and having a big treatment plan if they're not quite ready to change, because everything you do may go to waste. So you need to match your treatment approach to the patient's stage of change. So how do you know how ready someone is to change either their depression or their drug and alcohol use? There are scales you can use out there, and some are quite specific, standardized scales that are specific to certain substances like cannabis or alcohol, such as the readiness to change questionnaire is just one, or you can use a readiness ruler, which I'll show you right now. So this is the readiness ruler, and oops, I'm blocking it, but asking patients, what change are you thinking about making? How ready are you to make this change right now on this ruler out of 10, where 10 is very ready and 0 is not at all ready, or any number in between? So how ready are you to change right now out of 10? How important is it that you make this change? And you can also look at how confident they are at being able to make this change. That will give you a clue about whether you need to do certain things in treatment to bolster their confidence and whether they're likely to drop out. For instance, if they're not very confident about making this change, you need to be on alert for treatment dropout. And how ready are you to make this change? If you're faced with a patient who's not at all ready to change, it's time for lots of motivational interviewing. On the other hand, if you get a patient who is ready to change their alcohol and drug use and their depression, they're scoring, 8, 9 out of 10, you could pretty much dive into treatment at that point. But at every subsequent session, you would still need to assess readiness, as it can and will fluctuate frequently. Another way you can assess readiness to change is to use standardised questionnaires. As mentioned before, this is a good quick one that you can give to someone, which will look at both whether they're ready to change their drug and alcohol use and their mood disorder. So you basically get them to tick which one applies to them. For instance, I don't think I have a drug and alcohol or mood problem. I may have a drug and alcohol mood problem, but don't want to do anything about it right now. Or I have a drug and alcohol or mood problem, or both, but I'm not ready to do something about it right now. Or I have a drug and alcohol mood problem and I am ready to do something about it right now. That last one, where they're ready to do something, they're the easiest clients to work with because you can pretty much jump into treatment because they're ready. The first three, though, will require lots of motivational interviewing, particularly if they don't think they have a drug and alcohol problem or mood problem or both. So what are the main alcohol and drug treatment strategies you would use with this comorbid population? I'll go into each one separately, but these are the main CBT treatment strategies you would use in addition to motivational interviewing. So you'd start off by identifying high-risk situations where they're likely to use alcohol and drugs and teaching patients problem-solving skills for these high-risk situations. You may or may not need to use or teach patients alcohol or drug refusal skills, depending on how good their assertiveness skills are. You would also probably look at managing cravings and identifying and challenging irrational beliefs about alcohol, drug use and cravings as well, because that can sometimes maintain the problem. You talk about lapse versus relapse and develop a relapse prevention plan as well. Now I'll talk about each of these treatment strategies in a bit more detail. The most important, of course, is identifying high-risk situations where they're likely to use alcohol and drugs. And how do you work out which situations these are? And the best way is to actually get clients to self-monitor their drug and alcohol use, so quantity and frequency of use, or you can go back retrospectively for the past month or 3 months using the timeline follow back method, which basically uses a calendar or a diary as an aid, and you go back starting from yesterday, either 1 month or 3 months, each day retrospectively, asking them if they used any alcohol or drugs on that day, how much, who they were with, and try and see if there's a pattern between heavy alcohol and drug use and specific situations. You can also use standardised self-efficacy scales as well to identify situations in which the client says they're sort of not confident in being able to abstain or cut down. That can be really important in treatment. But more often than not, high-risk situations are people, such as partners, drinking buddies, colleagues, places, so it could be the bar, or it could just be at home. And more often than not, patients with quite severe depression are usually not very sociable and tend to use or drink at home alone. So being at home after work could be their high-risk situation. Mood states are also common high-risk situations for using substances. And with depression, it's usually a low mood or an exacerbation in an already low mood, but it can also be a positive mood or an improvement in mood that could trigger further use. So keep these high-risk situations in mind when you're considering the next step in treatment, which is problem solving. So problem solving for alcohol or other drug high-risk situations might seem like a skill that you don't need to teach patients, but you'd be surprised how many of them actually need help with this technique. It's not unusual for patients with quite severe depression or mood disorders to struggle to problem solve anything in their day-to-day life. So you may need to get down to basics and teach them problem-solving skills, and you do this by identifying the high-risk situation, which hopefully you did using scales or the self-monitoring or timeline follow back. With the patient together, you'll brainstorm all possible solutions. Once again, patients who are quite depressed will struggle to come up with solutions. They may need your help or input. Similarly, with each solution, you identify the pros and cons of each and get the patient to pick one or two solutions to try over the next week or so. Patients with depression struggle to make sometimes even what seem to be like the simplest of decisions, so they may not be able to pick one or two easily, or they may spend a lot of time trying to decide. This is where you may need to prompt them a bit or push them along a bit with their problem solving. And you may need to develop quite a specific action plan for each high-risk situation. I always write it down because patients retain very little information in the 50-minute session they have with us. So I write everything down, give them a copy of the detailed action plan, send them away for homework, get them to try it out, and then in subsequent sessions you review how it went. Which strategy worked, for that high-risk situation? Which didn't work? Do you need to come up with a different solution for that high-risk situation? So this is something you would do for every high-risk situation, and do this always in treatment. Teaching clients alcohol or drug refusal skills is also an important component of treatment with this comorbid population, especially if they're not very assertive. And unfortunately, patients with depression are sometimes not assertive, and their inability to say no to offers of drugs or alcohol could be maintaining their drug and alcohol use problem. And it's really important to teach patients these basic refusal skills, role play it in session, and I like to role play the wrong way to say no and then the right way as well, just to show them what a difference it makes by using the right techniques to say no. So you want to teach patients to maintain good eye contact with the person that's offering them drugs and alcohol, and often patients with depression have very poor eye contact with others, which makes them actually appear not very assertive at all. Teach them to give short responses such as no thanks to offers of drugs or alcohol, teaching them not to hesitate in their answer and to repeat themselves if need be, or suggest an alternative to alcohol or other drug use. Tell them not to be vague or give excuses or feel they need to justify why they're not using. And if all else fails, get them to leave the risky situation if they feel they can't effectively refuse an offer of drugs or alcohol. Teaching patients craving management techniques are also an important component of treatment with this comorbid population. You'd start with just educating them about cravings, explaining that they're normal and everyone gets them, and they are usually time limited and they go away. Try and identify triggers for cravings for them if you can. It could be people, places, things, days of the week or times of the day, or certain mood states, usually negative mood states. And try and identify any irrational beliefs they may have about cravings, such as, for instance, if I don't use when I get a craving, the craving will send me mad, or my craving will get worse and it will never go away. So try and identify those irrational beliefs and then challenge them. Teach them the 3 Ds, so delay, using, distract yourself, and then decide. They're the main components of craving management. But look out for really negative comments about cravings that patients with depression are really good at making, such as, they'll never go away, I'll always have cravings, there's nothing I can do about them, and try and challenge those irrational beliefs as well. Another key component of evidence-based treatment for comorbid drug and alcohol use and depression is teaching patients behavioural activation. Not only does it improve their depression, but it also reduces their reliance on alcohol and drug use. So it kills two birds with one stone. And Although behavioural activation was originally introduced for treating depression, it is also a huge component of any alcohol or drug treatment. And what you're doing is you're getting patients to identify that there is a link between behaviour and mood. And activity breeds more activity and will help to lift one's mood. And when patients are giving away alcohol or drugs or learning to cut down, they'll often report that life's a bit boring, there's not much else to look forward to now that they're no longer using. So this is where behavioural activation comes in very handy. And you'd start by identifying things that they're currently doing that they enjoy other than alcohol and drug use, and things they used to enjoy in the past but they haven't done for a while. And then look at new hobbies and interests that they can engage in that they've always wanted to do but never gotten around to. And the behaviours don't have to be complicated. It can be something quite basic, such as getting a coffee, going for a short walk, or sitting out in the sun. It doesn't have to be a different hobby each day, which can sometimes be too overwhelming for patients with depression. And we know that behavioural activation works both with depression and comorbidity because it helps improve structure in a patient's day. Often they don't have any structure when they're depressed, and it helps them to set priorities, which they often struggle to do when they're feeling quite low. It also helps with decision making, which, as we said before, is often quite poor in people with depression. They struggle to make even simple decisions such as, should I walk down the street and buy a coffee or not? And they can often take a long time to make decisions, and behavioural activation can often increase the chance of them completing an actual activity rather than just talking about it. And in the end of the day, it increases their sense of control over how they're feeling and their sense of control over their substance use as well. I like to get a calendar out and get patients to fill out their time in advance for the next 7 days, keeping in mind that they may need to have a plan B for some of their options, but to try and have some sort of activity during the day, especially at times when they used to use or drink at that time. Another really important but often overlooked treatment component for this population is actually monitoring their mood. Not only is it important for evidence of any sort of change or no change, but it can help identify the link between mood and alcohol and drug use. And it's really important to get patients to monitor from day one. And it doesn't have to be complex. They can use a journal, a chart. There's lots of free apps that monitor moods, or they can use an online program. At the end of the day, it has to be the client's preference, whatever's convenient for them, almost personalised. It can be as simple as rating their mood out of 10 each day and just jotting a number in their diary out of 10 at the end of each day for their average mood for that day. Or they can do it out of 100 if they want. It doesn't have to be out of 10, whatever they like. So it has to be client preferred, convenient and personalised. And it's really important to keep doing this throughout treatment. And even once treatment's finished, I recommend patients continue to monitor their mood, even if their moods improve significantly, as a way of looking out for possible future lapses or relapses in terms of their mental health. Now, a large component of treatment with this comorbid group is cognitive therapy. Not only is it important for challenging irrational beliefs about their alcohol and drug use, but also about their mood and the way they feel about the world. Patients who are depressed, according to Beck, will usually have a negative cognitive triad, it's called. So really strong negative beliefs about themselves, the world, and their future. Your role in treatment is to identify these thoughts or beliefs or cognitions and help the patient to learn how to challenge or question their negative automatic thoughts. And you'd start by, first of all, identifying the thoughts, asking them to look for the evidence for the thoughts. Are there alternatives? What are the advantages and disadvantages of thinking this way? And what sort of thinking biases or thinking errors are they making? Depressed patients may need a lot of assistance with finding their thoughts, identifying their negative and challenging them. But by the end of treatment, you want them to be able to identify and question their own negative automatic thoughts by themselves. But they may need a lot of assistance with this very early on in treatment. So not only will you be identifying and challenging irrational thoughts and beliefs about themselves, the world and the future when they're depressed, you'll also be looking at beliefs about their alcohol and drug use or their problem. And often they will have quite irrational beliefs that are quite firm and strongly held that will maintain the addiction. So I've got a list there of some common beliefs that you would help identify and challenge in session. And the most common one in this population is that, you know, alcohol and drug use helps my depression, it lifts my mood, it gets rid of my low mood. And self-monitoring can help to show them that it doesn't always, and is it the best way to manage their depression? If it's such a good fix, why are they still depressed? Sometimes I'll think, you know, it's the only way to feel happy. It's the only way to manage my pain, physical pain or emotional pain. And your task is to help them gently challenge this to realise that it's not the only way to feel pain, to manage pain or feel happy. There are alternatives. Another common irrational belief in this population is that life is boring without alcohol and drug use, and that's where the behavioural activation can help challenge that. Similarly, I need alcohol or drugs to function. I can't get out of the house without them. I don't have the willpower to stop. Those sort of irrational beliefs about their substance use can maintain the addiction long term, so it's very important to identify them in treatment and challenge them with the patient and teach them to continue challenging any beliefs they may have which are irrational. Another big component of treatment for this population is to develop an alcohol and other drug and depression relapse prevention plan. And it's ideal if you do this before a relapse, but not always possible. And you start by educating them about the difference between a lapse and a relapse, and just discussing that, you know, lapses are normal and we want to stop them from becoming full-blown relapses. And it's good if you have a formal written plan for both an alcohol and drug relapse and a depression relapse, because often the triggers are completely different. But you'd start by looking at, you know, what are some of the early warning signs that, you know, you could be going back to heavy drinking, or that your mood may be dropping. It could be things like staying in bed longer, avoiding socialising, feeling irritable, or thinking about alcohol more, looking for alcohol at home, and then looking at identifying what usually are your first signs of lapse or relapse, and most importantly in this formal plan, who can the client ask for help? It's good to have a list of options and contact numbers of people who will be able to help or services, and it's good to finalise this plan well before there is a relapse or a lapse, and to have this plan preferably in writing and review it if need be. But it's important to look at, you know, early warning signs and first signs of lapse for depression separately to the alcohol and drug use, because sometimes they may not be the same. Now, that were the main clinical components of evidence-based treatment for this population. What I'll talk about for the rest of today is some of the key clinical challenges of working with this complex group. And I'll talk about each one separately and some strategies to minimise these effects. But usually it's treatment non-compliance, treatment dropout are huge, very common. Motivation to change fluctuating a lot is another challenge. And more seriously, suicide risk is very high in this group, as is helplessness and hopelessness. And the fact that this population come with other comorbidities in addition to the two that are already there, due to the complex psychosocial problems that come with having a comorbid depression and substance use disorder. So how do we prevent treatment non-compliance, and how do we reduce dropout rates, which are really high in this comorbid group? First, try and look at removing as many treatment access barriers as possible. Make it as easy for the patient to attend treatment, to complete homework and things like that. So remove as many barriers as you can. Use telehealth if you can on days where they really can't get out of bed and can't get to appointments. So remove any barriers that you can see, whether they're real or imagined. The next step would be to make sure you assess goals regularly, so weekly. Expect them to change. They're not always going to have the same treatment goals that they did when you first saw them at assessment. And I like to check how satisfied they are with treatment regularly. You can do this on a weekly basis after each session using a scale like the Miller's session rating scale. Or if you've planned to see someone for 8 to 12 weeks, you could have a mid-treatment review at about week 4 or 6 and just ask patients, how do you find treatments going? Are you finding this helpful? Do you think you're improving? Is there anything that you'd like me to do different in treatment? And overall, try and enhance the alliance you have, the therapeutic alliance with this group, because they are more likely to drop out than others. Try and make treatment less complex if you can. Sometimes, we jump ahead too much. We give patients too much homework, too much work to do. And when they're depressed, it's difficult for them to even do small things. So try and make the treatment regime less complex and suit it more to the stage of change that the patient's at. And always check for drops in motivation to change. Remember, they're completely normal. Motivation will fluctuate. Don't expect patients to always be ready to change every session, and assess motivation for depression and alcohol and drug use separately. The other thing to look out when working with depressed patients for a long time is compassion fatigue in ourselves. Often if you've got a very big caseload full of patients who are quite seriously depressed, it can feel quite draining. So that's something to keep in mind as well. It can change your outlook and make you appear more pessimistic, and your approach will need to be altered. So look out for compassion fatigue, which is also very common when you're dealing with this population. Now, we know that substance use increases suicide risk, as does depression. So this population are at very high risk of suicide. We know that just having an alcohol use disorder alone, you're more likely to complete suicide. And if alcohol is consumed in minutes or hours before an attempt, it's more likely to become lethal. And they found that, about 70% of suicides contained a blood alcohol concentration at the time of their death. And alcohol intoxication in particular is linked to more lethal attempts. Drugs also are linked with more lethal attempts, but alcohol has the highest risk, and out of all substances, cannabis actually had the lowest risk of suicide in drug and alcohol users. But they're just figures. It's important to assess risk regularly and keep in mind that it's greatly elevated in this comorbid group. So why does this population have such a high suicide risk? There could be a number of factors. Often it's purely the alcohol and drug use, the impulsive behaviour associated with that. Often it's also the disinhibition that the substance use or alcohol intoxication could cause. Or it could be due to the depression, the despair, the hopelessness depressed patients often feel, and their negative outlook in life increases their risk of suicide. So keep this in the back of your mind when you're seeing every patient with comorbid depression and substance use, because their risk is quite high. And it's important to spend time managing suicide risk. And that means assessing risk regularly. Even if at assessment they were low risk for whatever reason, keep asking, keep assessing, because they are at such high risk. Always look at whether they've had past attempts, thoughts in the past, what their protective factors might be, whether they've currently got any plans, any means, any thoughts, whether they identify alcohol or drug intoxication as a risk factor for suicide. We know it leads to more lethal attempts, but do they identify that? And really look at the role of their alcohol and drug use on their suicidality. For instance, a lot of patients are unlikely to act on suicidal thoughts unless they're intoxicated. Is this the case for your client? And have a safety plan well before an attempt. So at assessment, even if someone is low risk where they're saying, no, I've never thought about suicide, I don't have any plans or attempts, it's still good to have a safety plan just in case this were to change at some point in future. They have a list of contacts or support services that they know could help in case they are one day at risk of harm to themselves. Another challenge with working with this comorbid population is the helplessness and hopelessness that they often report and how that can actually hinder progress in treatment. We know it leads to treatment dropouts. We need to be aware of it, so always assess helplessness and hopelessness. And you don't need to use fancy scales. You can just ask them, do they think this treatment will work with your help? Are they pessimistic about treatment even before they've started treatment with you? Do they think it's not going to work? If that's the case, they're more likely to drop out and have a worse sort of prognosis. So your role as a clinician would be to try and identify helplessness and hopelessness and try and convey some realistic optimism and enhance their self-efficacy and their confidence. Are they confident that they can do well with your help? If not, how do we enhance that? One way is to identify past achievements or successes they have. Doesn't necessarily have to be in terms of abstaining from substances or treating their depression. It could be identifying past achievements in other aspects of their life that are not related to their mental health. And the final challenge of working with this population is dealing with multi-morbidity, which means it's complex enough you're dealing with depression and their substance use, but you need to realise that there are other comorbidities as well that could be playing a role in their progress. So your task will be to identify all comorbidities, not just mental health, but physical health as well. And in terms of mental health, the second most common comorbidity in this group is anxiety. So it's usually a panic disorder, obsessive compulsive disorder, and PTSD. You need to keep that in mind when treating a patient because it could complicate things further if you ignore the extra comorbidities. In terms of health comorbidities that occur in this group, the list is endless. I've just added a few there, but hypertension seems to be the most common, followed by metabolic disorders like diabetes, obesity, sleep disorders, sleep apnea, and then true pain disorders as well. So you need to make sure you identify mental and physical health comorbidities as well, and you don't need to be able to treat them, but just assess, be aware of them and refer them on for treatment. If it's something that's out of your training, that's fine. Being aware of them is the most important thing, and you need to continuously monitor these comorbidities to make sure they're not being exacerbated by something else. So that was all we have time for today when talking about dealing with this complex group. And just now, if anyone has any questions they'd like to ask, fire away.
Thank you so much, Vicki. That was excellent. We have had some questions that have come through, and I am going to start us off by following up on one of the strategies that you mentioned, which was mood monitoring and activity scheduling. I was wondering whether you had found any benefit to asking your patients or clients to keep track of their sleep patterns and diet, and how that related to their mood and or cravings as well. We lost you, Vicki?
Yep. Oh, can you hear me now?
Sorry. Yes, I can hear you.
Sorry, I was talking to myself. Yeah, it's very useful to monitor sleep, diet, everything if you can, as long as the patient's willing to do it, because sometimes I find when they're quite severely depressed, just getting them to monitor depression alone is tricky enough. So whatever they're happy to work on, and make the monitoring as easy as possible. Nothing too complicated, because they're less likely to do complicated things, as we all are. So yeah, I think that's a great idea.
So working with where they're at again. Yeah, thank you. And we've had some other questions come in. A question from Tony, that there's the need to identify thoughts, negative, irrational, or hopelessness, but some people also struggle to identify their feelings and emotions, and whether you had any comments on that.
Yeah, that's tricky. Like, I think most of our patients struggle to identify core beliefs and thoughts, and you might often have to go back into the last time they felt really low, or the worst they felt earlier today, and then ask them what they were just thinking about, if they can remember, and work backwards from there. That can sometimes be useful, but it's true, a lot of them are really not aware of their thoughts and beliefs. And there are some nice questionnaires you can use to assess beliefs. But in terms of identifying thoughts as they arise, that's a really important skill that we need to teach patients. And sometimes I'll spend a couple of weeks doing that before I do the cognitive challenging. So I make sure they're really good at identifying their negative thoughts, and then move on to teaching them ways to challenge them. So it can take a while, especially if they're really not aware of what they're thinking about.
Thank you. A question about the screening tools that you mentioned, and in particular some workplaces that have initial intake and assessment that's built into their assessment tools that are built into their intake and referral decision support tools in this particular question. Wondering how that any screening tools that you've suggested might fit into those. Don't know if I've verbalized that question very well.
Yeah, look, I think there are lots of screeners you can use and formal assessment tools, and you can start off with like basic screeners, and you can go to more advanced structured clinical interviews, which obviously take longer to administer. But they've found that the best way to screen for depression is just to ask 2 short questions. And that is, have you been feeling low, sad, irritable, or, depressed in the last 2 weeks? And if they say yes to that alone, then you should assess further. But if you've already got your own sort of depression tools built into your assessment package that you use at your workplace, and they work, keep using them. It's only if you're looking for other ones, the best ones are probably your DAS-21, your K-10s. The Hamilton rating scale for depression is good too, but it's really up to you what you would like to use, whether you want to use just a basic screener or you want to go into something more fancy and time consuming. But I think it's personal preference. And if you've got something built already into your assessment package and it's working, use it. But if it's not, maybe start looking at K10 or the DAS-21 instead. If they're not already in your assessment package.
Thank you. I really love that you mentioned lapse and relapse and the importance of normalizing lapses as a part of a person's recovery. We have a question about this, but I'm also curious to know how you explain the difference between these to your clients.
Yeah, well, look, lapse is a little mistake, I explain it, as opposed to going back to a relapse, which is your worst pattern of substance use before. In terms of a mental health lapse and relapse, I'd say a similar sort of thing. So a lapse is where you have a couple of days where you're feeling low, but you can pull yourself out of it. A relapse is where you've actually at your worst again. So it's a backward step is a lapse. A relapse is going back to your worst sort of state. And it's important to ask about lapses and relapses, not just for the substance use, but for the depression as well.
Yeah, and really important what you mentioned as well about identifying the early warning signs for both.
Yes, which often they're not aware of, and you may need to go back retrospectively into their last little lapse and relapse and see what was happening just before that. So sometimes they're not totally aware of the early warning signs.
Mm-hmm. A question about whether you could expand a little bit on the link between disinhibition and suicide risk, and how disinhibition might show up or what it might look like when people are depressed.
Look, I think disinhibition is interesting because if someone, when they're using substances or alcohol, the way you would look out for it is a complete change in their behaviour, something that they wouldn't do if they weren't drinking or using drugs. So they may have more confidence, be more outgoing. Sometimes it can be making decisions without thinking about it. And that's the danger with suicide, is often the disinhibition from the substance use is it shows up in making major decisions very quickly without thinking about them. And for each patient, that disinhibition will look completely different. So it's important to do like a proper functional analysis and ask as many questions as you can about what they like, how they present when they're intoxicated. If they're even aware of it, sometimes they're not aware of the disinhibition and other people will have pointed it out. So I often ask people, you know, have you ever ended up in hospital while you're intoxicated, or done or said things that you really can't remember, but other people said you did that were out of character for you? Have you ever gotten into fights or arguments with people you wouldn't normally? So asking about what's not usual for their behaviour, something you wouldn't see if they weren't using drugs and alcohol. And that's probably the important thing, is the out of character sort of behaviour. And I suppose trying to get a really good history from them about that.
Thank you. And I'm aware that we haven't gotten to all the questions, but Vicki, are you happy for me to send those to you in an email to just follow up on? And
yes,
sorry that we haven't got through them all. I'm sorry about that.
No problem. And I'll write back as soon as I can.
Thank you very much. So just to follow up before we finish, to let you all know that you can find out more information about our guidelines, which this webinar series is linked to, and also our other resources at our website, which is there on screen. And I want to thank you all again. And of course, thank you, Vicki, for such a fantastic webinar today. I had lots of comments in the chat for you, which I'll pass you on later. And if you're interested in viewing this recording, registering for our upcoming webinars, or having a look at our library of past webinars, you can do that at our website. And to let you know that our next webinar is scheduled for the 16th of September, and that will be with Dr. Eddie Mullen, who will be talking about neurodiversity and substance use. But until then, thank you again for joining us, and thank you so much, Vicki. Please enjoy the rest of your day, everyone.